Thank you, Nishit sir. It's a privilege that you are with us. Now we can ask questions and have clarity about what we have listened with the speakers. Is there any question with anybody? Dr. Ramakant, there's a question for you. Dr. Ramakant, you there? Dr. Ramakant, you there?
Yeah, Ramakant is there.
Okay. So Ramakant, we have all seen that video by the technique by Dr. Din Shaw, where he uses fiber wire, puts some knots and fixes with more or less the same technique. So you're anyhow using fiber tape, which has a bigger and broader surface area of contact, gives a better compression. So what is the need of adding on the Indo button with a fiber wire along with using a fiber tape? So have you encountered any problem with using only fiber tape or fiber wire? That's why you have used additional fixation device. Ramakant, you have to unmute yourself.
Yeah. To begin with, actually, we have been using this only fiber wire initially. So I learned these techniques from Sundar sir. So I've seen that Sundar sir beginning probably in 2015 or something when he started, we had started using with the fiber wire. But what happened was there was a lot of slippage and sometimes the fiber wire used to get cut, probably because of initial technical hitch or not. And then when the fiber tapes have started coming, so when we used it, so there was a good snug fit of the PCL around the neck of the PCL to the attachment of the fragment. So since the fiber tape is a broader one, so it had a good control and good like tight noose around the fragment. So that when we try to pull, so that gives good compression on the fragment. So that was one thing. And then when we started using the fiber wire with the button, so there were some 3-4 cases where probably because of the instrument or something and fiber wire getting damaged and then it used to get cut. So that's why we moved to the fiber tape. That was the first part of the question. And then the second is we have used both just to get a double fixation, as I told in my presentation. So when we put the button and then when we try to pull it, because initial few cases, there was some secondary laxity when we saw in the patient's follow-up. So initially when we started, there was a secondary laxity. So that's why double fixation and then triple fixation with the suture post we had put. Yes, sir. Nishit, sir.
Ramakant, that laxity was clinically bothering the patient?
Yes, sir. Clinically, it was not bothering the patient, sir, but it was like grade 1 or grade 2 posterior sag, which we feel in most of the follow-up patients. In PCL reconstruction, either because of grafts stretching out or the strength of fixation was not sufficient, sir. So it was not clinically significant, but when we see the patient during the follow-up, we can feel some laxity in the PCL fixation. And as I told, we have published that there were some 2-3 cases of non-union as well in arthroscopic fixation as well. So that's why we have evolved to put the button and also the suture post to give good strong fixation for the PCL, sir.
Okay. Okay. And what is the rehab?
Rehab, we keep it absolute no mobilization of knee for 3 weeks. And then after 3 weeks, we start prone knee bending, sir. And non-weight bearing or touch weight bearing for 6 weeks. And then partial weight bearing for 1 or 2 weeks. And then full weight bearing from 7th or 8th week onwards, sir.
Okay.
One comment, Dr. Ramakant.
Yes, sir.
I have done few of the PCLs repair, very small number. But what I could see that the tunnel which you were making were on the sides of the crater. I suppose that I
below on the side of the crater.
Normally, I try to make it approximately 2 to 3 millimeters below. The purpose is it pulls the fragment back to its crater. And secondly, I always use 2 fiber tapes, not 1. One, as you have mentioned rightly, we circle around, put a knot, and use it as a holding fiber tape. And the other one, what I do, I'll take your this ultra first pass mini device, is a small device, and just pass that fiber wire through the substance of the PCL, and then you take it back and you cross it over and take out from the different tunnel. The medial one will go lateral, lateral will go, so that it creates a cross over the bony fragment and puts it back into its position. I think with the fiber tape, things have changed, and definitely we have evolved as far as PCL fixations and repairs are concerned. And with my limited number, I have not faced any major issue. And but my patient, they are low demand patient, and maybe I'm able to get away with that.
Yes, sir.
Ramakant, another small technical tip. So
Yes,
you're
sir.
using button with the fiber wire, correct? And the fiber wires are passing through infromedial and infralateral tunnel, which is outside the crater, correct?
Yes, sir.
So is there a problem when you are trying to manipulate and maneuver the button over the fragment? It might just try
Yeah,
to
it
go
will slip.
down. So do you have to maneuver a little bit?
Yes, actually, yes, there's so many occasions where the button used to come below the fragment. So what we do is, so we put a suture retriever and then lift the button, keep it on the fragment, and then ask our assistant to uh, pull it slowly so that the button doesn't flip outside the fragment. So it has happened many times, and it keep happening every time actually. So we have to ask our assistant to pull either medial wire or the lateral wire sequentially, so just so that the fragment is reduced and also the button is placed posterior to the fragment.
Yeah, one last question. You said that one patient has this vascular compromise in your case. What exactly happened? Can you share with us so that we are more sure what not to be done?
Yes, yes. So that case actually we had from past 5 years, probably we would have done around 35, I think, mostly by Sundar sir, and I've been doing only since last 2-3 years. And that case, there was a venous injury. I think the popliteus vein was injured because from the shaver, and then we found it immediately in the post-op, and then since Ganga plastic team is well versed with this, so they had come in and then repaired it. So there was a gross swelling. Those clinical photos also has been put in that paper. So we had one case so far of probably 35 to 40 cases.
Yeah, thank you,
It
Ramakant.
is little technically demanding, and we have to be
It
careful.
is very technically demanding. And Dr. Sanjay, you said that you put a suture through the substance in the popliteal fossa.
No. From anterior side.
Okay.
From anterior side, I use
That is what I usually do. That two sutures through both the bundles, and then just pull it on the back side and then pull it out.
intra-substance, it will not slip, it will not bite out, and you are not strangulating the ligament
Absolutely.
to circling.
So my problem attention for the Dinshaw technique was that it was too much strangling of the PCL,
True.
with all this so many knots, and then when you pull. So whether you say that there is a sliding knot or not, but probably they will become tight when you pull those knots, So that was I had always apprehension about a Dinshaw's technique.
I cross the fiber tape over the bone and then pull it. So actually, it will not have a constructing effect.
Right.
So we have a question in the chat box. What is the ideal PCL graft thickness for reconstruction? Dr. Vijay asked this question. Ramakant, Nishit sir, what's your take about this? What's an ideal PCL graft thickness?
If somebody is going to do only PCL reconstruction, then around 9 to 10 millimeter will be the ideal thickness of the graft. But nowadays, lot of I do is augmentation, especially introlateral bundle, and that is why even 7 or 8 millimeter graft is sufficient, because you have all original fibers with you. Just you put augmenting on this, and that becomes because otherwise what happens that Sanjay bhai, I wanted to ask you, or Ramakant, I wanted to ask you that if you do augmentation, if you put too thick graft, do you face any problem of postoperative knee stiffness and you have to do a manipulation under anesthesia?
No, sir, we have not encountered any of this sort, sir.
But do you do augmentation?
Augmentation for PCL, we don't do.
That is what. But the thing is
Augmentation
that,
with the fiber tape, sir. Ask. Augmentation with the fiber tape you are asking.
No. Augmentation in the sense that I keep the original PCL.
Original PCL. Okay.
And then I just put the new
Biological
PCL of the
augmentation.
original PCL, you know.
Yeah.
Yes, sir.
That is what I'm. But that what happens that it makes the notch more. There are a lot of fibers along with the ACL,
Yes.
and that is why I have to do a manipulation after 2 months, 2.5 months in a few patients.
No, probably we have not encountered, because most of the time probably we are removing the remnant fibers as well to get a clear view, and we are going to put a 10 mm minimum diameter of it, because both semity or sometimes semity and both gracilis we put in a multi-ligamentous situation. Now the peroneus is also there, so peroneus with some gracilis to get the diameter 10. So we have not got a stiffness as such, sir, but the laxity we have seen in few cases.
So you use
Strength is
BTB.
not strong.
Use BTB.
So Ajit, Dr. Ajit. So in your presentation, you stated that you have to correct the bony deformities or bony abnormalities first, and then go ahead with soft tissue repair of MPFL, correct?
Yes, sir.
So in a scenario of valgus knee, when the patient has both the knees valgus and you have a significant valgus, so you correct the valgus on one side along with doing an MPFL. So what happens to the other side? Because now the patient has an asymmetrical kind of presentation. So how do you go about it? A valgus knee with an patellar dislocation or recurrent dislocation patellar, you want to repair an MPFL along with doing a correction of valgoid deformity.
So I feel it. If we are reconstructing, abnormal side, we have to go for a valgus correction first, then MPFL correction, and at the same time we have to tell the patient that your other knee also required a valgus correction, so that the future chances of MPFL injury can be reduced or subside.
So Sanjay sir, your take is same, that you want to correct the valgus in the other normal limb, you want to correct the valgus, or you would only go ahead with the correcting.
Right now, patient is there for a problem in one knee, and if you don't correct the bony deformity, it is bound to fail. My reconstruction is bound to fail. So we have to focus on that, with a caveat that I'll tell my patient that the other side also requires correction, depending on the stage, depending on the age of the patient, whether it just requires epiphysiodesis or something, a smaller procedure, maybe bracing, and that can help. So it all depends on actual clinical situation, but I would definitely advise a correction on the other side also.
Yeah, Dr. Rohit.
Yes, sir.
So you had any problem of restriction of range of motion or maybe a tight knee when you're doing a, because the only thing is you don't know how much are you tightening on the lateral side when you're doing a tenodesis. So any tips and takes about how to avoid that over tightening on the lateral side when you're doing this technique?
Yeah, so the most important reason of over tightening initially was when we were doing it in the external rotation, the fixation of the LET graft in the external rotation of the tibia. So you have to keep it in 30 degree of flexion and in neutral rotation. At that time, it won't be over tightened. And also while closing the TFL gap, at that time, you should not make it over tightened. So that reduces the lateral compartment pressure significantly.
So
if you see the original Lemar technique, he used to use staple.
Yeah.
Those were not used. And there's a recommended technique that you just hold that graft, you don't pull it. You just hold it so that it acts as a restraint. It is not pulling the tibia back. And once you put in a staple, it will not. Sometimes what happens when you are putting a screw inside, your graft gets tightened, your graft goes more into the tunnel. So we have to be really careful when inserting a screw.
Yes, sir, definitely. You don't have to apply extra force from the other side to make it.
That's a normal tendency. When we want to do reconstruction, we want to do it tight. so that we are happy that things are stable. But here we have to be happy keeping it a little loose.
Yeah, it should be lax, means it should not be too much time.
Yeah.
Nisha sir, you wanted to add something, I think. Sir, your voice is not there. Nishit sir.
Mic is not working, I think.
Okay. Abhinay, Dr. Abhinay.
Yes, sir.
So what's your choice of distal fixation on the tibial side? You would like to fix it with a tunnel on the tibia, or as you showed that you would like to use a staple there?
Sir, I think now screw is better, sir. Tunnel, using tunnel is better because bony to soft tissue fixation is good. That will be good, better. But because due to cost, I have to use the tunnels, staples.
But I feel when you are attaching the superficial MCL, you have a very large area of fixation. So if you use either some kind of spike washer or something to stabilize to its natural position, that can work very well. I use that in cases of superficial MCL eversions from distal side.
There is a comment by
There's a comment by Dr. Nagaraja that while doing arthroscopic PCL avulsion fixation, is it must to get hairline reduction of the fragment like an open fixation? Because sometimes post-operative X-ray shows fragment not reduced 100%, but the intraoperative we would have found restored ACL tension as well as the PCL. So is it required to go and get absolutely 100% reduction in cases of PCL? Because I think Sanjay sir and Nishit sir are from the times when PCL was handled more or less conservative. Now it is more or less operative. So they are in the best place to answer this question, either of the senior most guy.
We have seen the conservative era, we have seen the open fixation era, and we are working in the arthroscopic era now.
So do you want to get this hairline 100% reduction of PCL or?
Is not always possible when you do it on arthroscopic. Stability is first thing. I want my bony fragment to sit in the crater so that it get an environment and ultimately it can heal to a larger extent. When there's a very large bone fragment, fresh fracture, you might get a hairline reduction, but that is not the aim. The ultimate aim is to provide a stability and a bony contact. That's it.
Even in the chronic avulsion after 2-3-4 months, if you clean the crater and do some refreshening, you might see a gap, but if you see clinically, there is no problem with patients.
Yes, one I would like to add a point on it. So actually, that's why in our initial cases, I told there was few cases of non-union because we are not able to achieve the 100% reduction. So that is when we started doing this double and triple fixation, where first we just pulled the fiber wire and then tied it in the anterior cortex. Then we had added the button and then tried to pull the fragment again and then tied it in the anterior cortex and then the suture post. So each time when we tighten it, so probably the reduction was better. So after this triple fixation, we have not seen any cases of non-union so far. So
how much time it takes to do the triple fixation?
Sir?
How much time it takes you to do triple fixation?
It is bit longer, sir, but our operative time now it's like 1 hour to 1 hour 15 minutes we will be able to do. Mainly initial phase is what first half an hour will be like concentrated mainly on clearing the soft tissue and getting the identification. Half an hour to 40 minutes. After that, putting the wires and then pulling it takes just about half an hour, sir.
Okay. Okay.
So half an hour to 45 minutes is just to get the anatomy clear so that identify the fragment, identify the posterior cortex, and then clearing with the RF probe takes time.
What I understand that once we are doing these repairs, your fragment is like this and your sutures are going on the sides. So many of the time that fragment lifts and it's difficult to contain that. That's why I prefer to keep my holes down there and not so far lateral, so that my fiber tape is actually pressing the fragment to it.
Yeah.
Other, as I said, when they are crossing like this, they also create a buttressing effect on the fragment. So that prevents the lifting of the fragment, which is very common after PCL repair. And I think that is the answer for your this problem.
Sanjay bhai, do you put any like stainment pin or something in the posterior and retract the capsular part or the posterior part?
I normally do both medial lateral. So
Okay.
That's
No,
comfort.
that is compulsory. Yes, if you want to do PCL avulsion.
Sometimes I just put this Visinger rod and you put
I
the.
think that Visinger rod makes life more easy. You know.
Definitely.
Rohit,
And
Yes, sir.
you are working in a better.
so in your case, you showed that you had to, the tibial tunnel was at fault. Suppose you have to do the same case with the femoral tunnel, which is abnormal, and you have to recreate a femoral tunnel. So would you give any tips of then doing a tenodesis, because then you have already two tunnels on the femoral side for the ACL. Would you like to make some changes in your technique, or you would still go ahead and make another tunnel for tenodesis?
So as I have shown in my video also, you have a modified Macintosh procedure. So you can do that if you are not very much confident whether you can use a femoral tunnel. So, and the other option is also the staples, as sir told that initially that it was described with the staple only. So you can use either a staple or you can just revert it back on the Gerdy's tubercle and just tie it up. So that is another option, but initial thorough planning is more important. On the CT and everything you should plan beforehand that you can use it or not.
You can use that Macintosh technique, or you can use that Sebastian's modification of Macintosh, in which you loop it through the septum and bring it back to the tendon and suture. That is also a very good technique, because you need not to work on the bone, and then there's no problem of confluence of tunnel or those things.
Yes.
The only trouble is you need a longer graft.
Longer.
So I think we have crossed 9 o'clock. So thank you Ortho TV for giving us wonderful platform, and I would like to request Dr. Karamraj, our VOC secretary, to give in the closing remarks. And I thank everyone to be who have participated in this event. Dr. Karma, please go ahead. I think we can't hear you, Dr. Karma. No, your voice is. No, you're not. We can't hear you, Dr. Karma. So you have to unmute yourself. Okay, you have unmuted.
He has unmuted. There's some problem with the mic, I suppose.
So, okay. So thank you, everyone. Dr. Karma, we can't hear you. So sorry. So I'll address everyone on behalf of yours.
Yeah, okay, no problem.
Yeah. We can hear you. We can hear you. Go ahead.
Okay, yeah, thank you so much, AAUP and the President Secretary. I mean, you've done a great job of getting forms. It has been so kind of Dr. Sanjay Srivastava and Dr. Nishit Shah to preside over as panelists, and excellent talks by Dr. Rohit Pandey, Dr. Ajit Singh.
Okay. So we will wind up. Thank you, everyone. Thank you, Nishit sir. Thank you, Sanjay sir. You have always guided us. Keep guiding us more and more.
Yeah.
And,
Okay.
Okay, great. So now your voice was again gone in between, Dr. Karma.
Oh, yeah.
Again, it is gone. So Ramakant, we will be surely coming to Coimbatore, and I think all of us who are there on the this meeting, we all will be coming to Coimbatore and seeing you there. Thank you, Rohit. Thank you, Ajit. Thank you, Abhinay. You have been wonderful. All presentation has been wonderful. I'm absolutely amazed to see such wonderful presentation. When we were like 10 years back, we could not present like this. Absolutely hats on.
We are being modest here, sir. Thank you so much.
No, it's wonderful. Thank you so much. Good night.
Okay, good night.
Good night, sir. Good night, everyone. Thank you.
Good night, everyone.